There is a story about Big Ben and the Leaning Tower of Pisa. Big Ben asked the Leaning Tower of Pisa, "If you have the time, I have the inclination." Well, for many years I had been wanting to present this paper at RSNA conference, but couldn't manage it. Finally, it was Big Ben who was able to find me the time for this presentation. Gastroesophageal reflux is not a subject that can turn everyone on, but it is a subject which everyone will experience many times in his or her life. Gastroesophageal reflux symptoms and signs may be related to gastrointestinal tract. There may be pain, which may be abdominal or retrosternal, or referred to the arm, shoulder, back, neck, and even the head or the abdomen. The pain may be burning or constricting or sharp and bursting. Dysphagia is another major symptom, and globus is a sensation of foreign body in the throat. There may be painful swallowing or discomfort in the retrosternal region. A sensation of food hanging behind the throat or behind the sternum may be experienced by patients. Some patients may present with a bleeding. It may be insidious and the patient may only have anemia, or it may be brisk and the patient may complain of melena. There may be trauma to the mucosa, in which case we call it a Mallory-Weiss syndrome, or there may be full wall esophageal wall thickness trauma and rupture, and we call it Borhavis syndrome. There may be fistula formation, mediastinal abscess formation. Esophagitis may present with inflammation or with ulcers. There may be stricture formation with traction hiatus hernia. The normal squamous mucosa of the esophagus may be replaced by columnar mucosa, and we call that Barrett's esophagus. There may be neoplastic changes either in the squamous mucosal esophagus or columnar-lined mucosa. Dental erosion have been documented. Diverticulum formation with production of epiphrenic diverticulum is well known, but Zenker's diverticulum also owes its etiology to reflux. Dysmotility is a well-known but poorly understood complication or sign. Sliding axial hiatus hernia is extremely common, and patients may have a sense for a sudden defecation. It's a vasovagal syndrome or syncope. Some of the symptoms may be more general, and an unusual one is called Sandifer syndrome, which imitates a torticollis. There may be failure to thrive, weight loss may be present, patient may have debilitation or electrolyte imbalance. Some patients may develop globus hystericus reaction or even psychosis. Some of the symptoms are cardiovascular related, and the patients may develop tachycardia during nausea, which precedes vomiting. But during actual gastroesophageal reflux, there is a bradycardia. Sudden infant death syndrome has been connected to reflux. Vasovagal and vagovagal syncopes may occur. There may be simulation of coronary disease or simulation of myocardial infarction. Atypical EKG changes have been documented. There are pulmonary related signs and symptoms, and there are cough, asthma, recurrent infections due to aspiration, lung abscess may form. There may be chronic interstitial reaction with cyanosis and clubbing. Apnea may occur with choking or without choking. Some patients develop laryngeal spasm, and laryngeal stenosis have been documented. Again, I would like to emphasize that sudden infant death syndrome has been noted in patients with reflux when they have got pre-existing pulmonary insufficiency. There are important tests now for evaluating gastroesophageal reflux. The time-honored and the best is still barium and fluoroscopy with spot film or cine radiography or video documentation. Radionuclide scans have come into the picture recently, and they can document reflux and pulmonary soilage. And in the future, we may be able to document inflammatory changes in the esophagus. Manometry can offer findings on motility dysfunction and provide a landmark for pH probe. Extended pH study for 18 to 24-hour study can be done, and this is called Tuttle test. Endoscopy, either esophagoscopy or pan-endoscopy, provides visual documentation. Photographs can be taken, a biopsy can be taken under direct vision, and cytology can be obtained. Bernstein's acid sensitivity test is another useful test, and recently the acid clearing time test, which is a modified Tuttle test, has been added to the armamentarium. There are tests that show actual reflux, and they are barium swallow and fluoroscopy, though the sensitivity is rather low. Gastroesophageal CT scan and endoscopy are other tests. Now, the secondary changes or indirect signs of reflux are more important than direct demonstration of reflux. The indirect signs can be shown by barium swallow, endoscopy, acid sensitivity test, biopsy, manometry, and acid clearing test. Now, the indirect signs demonstrated by radiological findings are focal spasm of the esophagus, poor mucosal coating due to excess secretion, speculation of the esophageal lumen due to muscularis mucosal contraction, and occasionally one may be able to demonstrate transverse mucosal folds. Irregular mucosal edema and thickening may be demonstrated. Ulcers, either linear or deep ulcer, may be demonstrated. A rigid segment demonstrating limited distension may be shown only by fluoroscopy. Motility dysfunction may be present with changes in the tone of the esophagus, changes in the peristalsis of the esophagus, and onset or commencement of tertiary contractions. There may be hiatus hernia formation, which is due to contraction of the longitudinal muscles of the esophagus. Lower esophageal sphincter and upper esophageal sphincter dysfunctions may be present, and these may present themselves either with hypertonicity, hypotonicity, or with incoordination with peristalsis. Pulsion diverticulae have been mentioned before, namely Zenker's and epiphrenic diverticulae. Strictures, metaplasia, and malignancy or rupture have been discussed already. Here's the esophagus showing a small ulcer and a hiatus hernia. Another patient with a hiatus hernia and reflux now beginning to have a short stricture formation. A contrast study, double contrast studies, or a single contrast study have been discussed very strongly in order to demonstrate details in the esophagus. I think both have their importance. A single contrast study and large volume will be helpful in demonstrating the distensibility, and the double contrast study will be helpful in mucosal changes. And here we find the double contrast study showing the details of esophageal mucosa, which in this case has got chronic inflammatory changes and superimposed monilial infection. In some patients, there may be intramural pseudo-diverticular formation in chronic esophagitis due to reflux. And in this patient, which doesn't come out so well, there are fine spiculations and transverse mucosal folds in the esophagus. And you can find the lungs have got infiltrates, and this patient was a proved case of Barrett's esophagus. A short stricture with traction hiatus hernia can be well demonstrated by many methods, but radiology is superior to other methods because the lumen of the short stricture may be too small for an endoscope to be passed without trauma. And radiologically, we can demonstrate both the upper and the lower part of the stricture, and if there is more than one area of involvement. And in this patient, you find the contrast which has been given to be swallowed has extravasated into the left hemithorax. And this patient had a celebration with alcohol, followed by a bout of vomiting, which she tried to control till she went to the bathroom and landed up with a ruptured esophagus, with a full thickness rupture of the esophagus. Mortality and morbidity are fairly high in this unless immediate diagnosis is made. And here is another patient who was not very symptomatic, but who came in with a fistulous tract and a pouch or a pocket of abscess in the mediastinum due to a previous rupture of the esophagus. The lower esophageal sphincter is an important landmark. And here we find the lower esophageal sphincter has demonstrated hypertonic contraction following a reflux. And the spastic or systolic state of the sphincter has caused the proximal esophagus to dilate considerably. And in the second radiograph, you find the sphincter is beginning to relax. You may call it a diastolic phase of the sphincter. Motility disturbances are varied. You may find a ripple type of contraction or a corkscrew type of contraction. Some people call it a nutcracker esophagus. The pressure within the lumen of the esophagus is extremely high, and the peristaltic action is impaired, and there are tertiary contractions which have no direction. They move back and forth, and they are like the small bowel movement where the food has got to be mixed. And in these patients, there may be associated cardiac or pulmonary findings. And the patient you saw just now came in repeatedly with symptoms of myocardial infarction or anginal pains. And every time she had a pain, the esophagus had abnormal contractions, there were EKG changes, and the patient had also some wheezing and cough. And this is due to the common innervation of these three structures. Another patient who we saw some years ago had tertiary contractions with abnormal ring type of contractions. And we were following the reflux, and we could see that hiatus hernia. And in 4 years' time, this patient developed carcinoma of the distal end of the esophagus. And we had to keep that in mind. Abnormal contractions can begin to appear like rosary beads. And they're also been called Barseny-Teschendorf esophagus. Sometimes these localized area of beaded segments which contain tremendous intraluminal pressure may cause in a pulsion diverticulum formation. And when they are close to the distal portion of the esophagus, we call it epiphrenic diverticulum. They tend to get larger and larger and need surgical correction. Rare cases of diffuse esophageal muscle hyperplasia have been noted in patients with reflux. And we had 3 such patients, and it was a problem to deal with them. Myomotomy was done on one of them, and the reflux problem became quite severe. And patient developed a stricture following myomotomy. When the reflux causes dysfunction of the lower esophageal sphincter, there is a corresponding dysfunction of the upper esophageal sphincter. And you can see a patient with hiatus hernia and who has developed a spasm of the upper esophageal sphincter and in coordination between the deglutition movement. You can find overfilling of the vallicula and the pyriform fossa. Matter of fact, there is a posterior outpouching in this patient. There is a synchronous action of upper esophageal sphincter and the lower esophageal sphincter. When upper esophageal sphincter relaxes during a swallow, lower esophageal sphincter also relaxes. The upper esophageal sphincter relaxation is brief, whereas the lower esophageal sphincter relaxation is prolonged, often till the bolus reaches the lower esophageal sphincter. Trained yogis can open and close both the upper esophageal sphincter and the lower esophageal sphincter voluntarily. In such yogis, anesthetizing upper esophageal sphincter temporarily abolished this synchronous action. Reflux acting on the lower esophageal sphincter and causing dysfunction of the lower esophageal sphincter may eventually lead to upper esophageal sphincter dysfunction. The patient may then complain of globus symptoms. And even when the reflux material has not reached the upper esophagus, even when it is staying in the distal esophagus, the patient may show that he has got some sensation of foreign body in the postcricoid region. And some of these patients may eventually develop Zenker's diverticulum. Similarly, postnasal drip in the upper respiratory infections and in patients with impaired swallowing, there is a pooling in the vallicula and pyriform fossa. This causes an increase in the afferent impulses, which cause a dysfunction of the upper esophageal sphincter. This eventually leads to dysfunction of the lower esophageal sphincter, and the patients with upper respiratory infection may develop increased incidence of gastroesophageal reflux. Upper esophageal sphincter has a voluntary and an involuntary component. In some, there is increased danger of reflux entering the larynx during the sleep, as the voluntary component is not alert against a reflux. It is by developing control over the voluntary components, that is the superior, middle, and inferior constrictors, that yogis initiate their control over the upper esophageal sphincter and subsequently the lower esophageal sphincter. And here is a study that we did on some yogis who had control over their sphincters, who could open both upper and the lower esophageal sphincters simultaneously. The pressures were taken at the distal esophageal sphincter. And when he swallowed, during the time of swallow, when the bolus was crossing the upper esophageal sphincter, you could see the contractions and the relaxations in the lower esophageal sphincter. And we anesthetized the upper esophageal sphincter, and this synchronous action was abolished. And 20 minutes later, the synchronous action is beginning to reappear. And here are the patients showing the dysfunction of the lower esophageal sphincter and the upper esophageal sphincter with development of Zenker's diverticulum. And the upper third of the esophagus is mainly skeletal muscles, and the lower third of the esophagus has mainly smooth muscles. And in the middle third, there is a certain amount of superimposition. And when the tone of the esophagus changes, usually to a hypertonicity, the middle and lower esophagus begin to narrow down, and the upper portion or the cervical esophagus stays slightly dilated and tends to retain the barium for a long time. And you can see an example of the upper third of the esophagus beginning to be more dilated than the distal portion of the esophagus. And when the upper esophageal sphincter becomes incompetent, as in this case, you find that there is a reflux into the larynx. Here is a patient who has got hiatus hernia and reflux, and you can see that he is developing Zenker's diverticulum. You can see many cases with hiatus hernia and reflux without Zenker's diverticulum, but hardly any Zenker's diverticulum appear on their own. And here is a patient with a Zenker's diverticulum who had no clinical symptoms or dysphagia, but who had recurrent lung infections, especially in the middle lobe. And with a barium swallow, we demonstrated the Zenker's diverticulum and also the spill into the trachea and into the middle lobe. And especially when the patient bends forward, this spillover is seen to be well demonstrated. And this patient had lost his cough reflex. Here we see in the lateral view, as I asked the patient to bend or stoop forward, there is an easy spillover into the middle lobe bronchus. And we have not been able to get the Zenker's diverticulum on this, but you can see the hiatus hernia and the spillover traces of contrast retained within the lung. It is important to know about this Zenker's diverticulum because endoscopy or any procedure may be a major problem. Sometimes tablets, which can be traumatizing to the esophagus, may be retained in the Zenker's diverticulum. There may be perforation and pharyngeal abscess formation. In these patients, there was an intubation procedure and there was a rupture of the Zenker's diverticulum, and you can see air in the mediastinum. In patients who are chronically bedridden, you may find those patients who have got nasogastric feeding. The tip of the nasogastric tube, which probably was in the normal position, suddenly showing up in the middle of the esophagus. And this is a clear evidence that the patient had refluxed. And within a few hours or a day, you will find the lung changes. And this is not an uncommon situation. And you can find the lung abscess in this patient. When there is a massive amount of very acidic fluid entering into the lung, the patient develops an acute pulmonary edema called Mendelssohn's syndrome. But if it is an incipient reflux with which may just produce small areas of a reaction, and if there is any sepsis, then you get an abscess formation. Now we go to the investigations that will give us a measure or the quantitation of the reflux. And gastroesophageal CT scan has been useful in this, and long-term pH evaluation, that Tuttle test, has been useful for this study. Radionuclide studies in gastroesophageal reflux. The advantages are that radiation dose is low, it is simple and non-invasive, we can record a reflux episode, we can quantitate a reflux through digital conversion, we can evaluate competency of esophageal peristalsis and transit of the bolus or its fragmentation and retention within the esophagus. So we can evaluate the esophageal emptying time after a swallow and after a reflux. We can obtain time activity curves, graphs, subtractions, and linear accentuations. We can also detect pulmonary aspiration. The disadvantages are the anatomical details are so poor that we need X-rays with barium swallow for adequate anatomical detail information. The secondary signs of gastroesophageal reflux cannot be obtained except for motility disturbance and pulmonary soilage. Clinically, the secondary changes of reflux are more important than mere demonstration of a primary reflux or its quantitation. Another disadvantage is we cannot distinguish between true gastroesophageal reflux from a hiatus hernia from a spurious reflux from the vestibule or the phrenic ampulla. The presently used technetium-99 sulfur colloid has a short half-life, and a delayed postprandial reflux for pulmonary aspiration may be missed. And we need sophisticated units connected to a computer, more or less a dedicated unit, if other radionuclides are to be used. Endoscopy. By direct visualization using a flexible fiberglass unit which conducts external light source, we can do biopsy under direct vision. The advantages are gastroesophageal reflux can be seen directly and documented. Evidence of esophagitis can be seen and documented. Punch biopsy or cytology can be taken in order to do microscopic staging of esophagitis to rule out infective organisms and to evaluate any malignant or metaplastic changes. The disadvantages are we cannot evaluate distensibility changes of the esophagus. Sometimes large submucosal lesions can be missed. Punch biopsy may be inadequate or from the wrong place. It is an invasive and uncomfortable procedure. Bernstein test, esophageal acid sensitivity test. Advantages are the 0.1% hydrochloric acid can easily be introduced into the esophagus, and the patient's symptoms are reproduced quite well. The main disadvantage is that you cannot do a normal control. Next test is Tuttle test. This is pH test of esophageal lumen taken with a probe 5 centimeters proximal to the lower esophageal sphincter. The normal esophageal pH should be about 7, and the test is positive if the pH is below 5. Advantages are it is an accurate test if the reflux tint is acidic. We can monitor for 24 hours. We can connect to a computer storage for a replay. Disadvantages are that this is an invasive study. It is quite uncomfortable and it is inaccurate if alkali or bile refluxes. Manometry. Using a single or multiluminal pressure transducer placed within the esophagus, the pressures are measured and recorded by multi-channel external recording device. Advantages are we can evaluate secondary motility changes, we can evaluate peristaltic rate and amplitude, we can estimate the sphincter tone and its changes. The disadvantages are we cannot evaluate reflux directly. It is an invasive procedure, uncomfortable to the patient. It is time consuming. We cannot evaluate the anatomy or a hiatus hernia. The values change from time to time in the same patient and from machine to machine and with different techniques. Modified Tuttle test, called the acid clearing time, the esophageal emptying time. It may even take 1 to 30 swallows to empty the esophagus. The advantages are this test shows the integrity of the esophageal motility, and it also shows the length of time the refluxed material stays in the esophagus. Disadvantages are each swallow results in lowering of the lower esophageal sphincter tone till the bolus or the primary peristalsis reaches the lower esophageal sphincter. So this tends to end in reflux if the patient is in horizontal position and if the patient is made to swallow repeatedly. Repeated swallow of alkaline saliva may give false reading. This test must be preceded by a manometry, which should provide a landmark for the tip of the pre-H probe, which should be 5 centimeters proximal to the lower esophageal sphincter. Hiatus hernia and reflux. The rationale of therapy is to improve the lower esophageal sphincter competency, to decrease gastric acid, to improve esophageal emptying, and to improve gastric emptying. The complication of a medical treatment. The patient may become refractile. There may be initial response, but eventual aggravation due to side effects of the various drugs. There may be acute crisis occurring due to stricture formation or rupture, and there is a remote danger of cancer development. There may be complications due to repeated endoscopies, dilatations, and bourgeonnage. The surgical therapy is mainly aimed in order to prevent reflux. The gastroesophageal junction is restored into the abdomen by increasing the subdiaphragmatic portion of the esophagus, by augmenting the action of the lower esophageal sphincter, and by correcting any strictures in the esophagus. There are a number of surgical procedures. The major group are Allison, Mark IV, and Hills. These three procedures aim to tighten the hiatus, to restore the angle of esophagogastric junction, that is the angle of His, aim to anchor the fundus of the stomach, and in some cases provide a partial fundoplication. Next procedure is Colles procedure, which aims at lengthening the intra-abdominal esophagus. A gastric tube is produced in an isoperistaltic manner. Various surgical procedures such as Allison, Hills, Belsey, Mark IV, Colles, Nissen, Thal, and Angel Chick procedures have been done for correcting reflux and hiatus hernia. And of these, Nissen's fundoplication enjoys the highest and best reputation. Angel Chick procedure has recently been introduced, and we do not have adequate data. But Allison procedure has the maximum number of breakdowns. Nissen's fundoplication aims at wrapping the fundus around the esophagus. It may be done as an abdominal procedure or sometimes as an intrathoracic procedure. But after this procedure is done, there is a distortion of the EG junction, and radiological evaluation must take this into account, as there is a filling defect or a pseudotumor defect at the gastroesophageal junction. If there are surgical markers, the diagnosis is easy. If not, it can lead to confusion and inadequate or inappropriate diagnosis. And Nissen's fundoplication is not without its complications. There can be considerable amount of holdup at the esophagogastric junction, and there has been 8 to 10 hours esophageal delay in some of our patients. A perforation can occur, or occasionally the wrapped fundus can break down. And in this case, the broken down wrapped fundus is intrathoracic, and for all purposes, it appeared like cardiac tamponade or rupture into the pericardial region. The recent procedure, Angel Chick procedure, aims at wrapping a collar around the vestibule and to augment the lower esophageal sphincter tone. But there are certain problems such as anatomical recurrence and reflux recurrence. In all the surgical procedures, the morbidity includes perforations, leaks, bleeds, ulcer formation, stricture formation, gas bloat, difficulty to belch, obstructive signs and dysphagia, breakdown of the anatomical landmarks, misleading future evaluations, floating collars, eroding collars, or sinking collars have been documented. And mainly the symptoms and complications are treated and not the basic cause. Some surgical procedures may be compared to repairing a leaking dam from the wrong side. As we have demonstrated, the dynamic physiological activities are restrained or replaced by mechanical applications. I realize now that it is the cost efficiency that really catches one's eye. And so we go to the cost efficiency of these surgical procedures. If a modest rate of $1,000 per surgery is taken into consideration with about 5 days of hospitalization and 1 to 3 hours of surgery, it may be roughly $3,000 for each surgery. And this is a bread and butter surgery in many of the hospitals. And even if 50 operations are done in each hospital per year, and if 1,000 hospitals do it in one state or one country, and if there are 10,000 hospitals which do it all around the world, you can see the amount of money that is involved. And along with this, there is loss of manpower, the time of the patient, as well as the doctors and physicians. So there are a few other facts one has got to take into consideration. And if they don't want to see the facts, they are welcome to close their eyes in whichever way they would like to. So I had to reevaluate the entire phenomenon of reflux. So I went to the dictionaries, looked at it, and the definition just means flow backward. Vomiting, rumination, reflux, and regurgitation. They're all spectrum of the same phenomenon with considerable overlap. In reflux, the material may or may not reach the buccal cavity. In regurgitation, the material may enter or exit a buccal cavity or the nasopharynx. In rumination, the material reaches the buccal cavity. In vomiting and nausea, it forcibly exits from the buccal cavity. In vomiting without nausea, it again exits the buccal cavity forcibly. Snakes have played a very important role in human psychology, philosophy, culture, and in scientific studies. It was a snake which eventually led me to make this study on reflux phenomenon. Reflux in nature is not only an obligatory phenomenon, but it is quite essential. Many animals feed their young ones by eating and carrying the food in their stomach and regurgitating it to the young ones, sometimes even after 10 hours. Many birds feed and regurgitate and feed their young ones. The regurgitated material may come from the stomach or from the crop or gizzard or from pouches underneath the beak. Some frogs have recently been found to nurture the tadpoles in their stomach, and after 2 weeks, they bring out mature small frogs out into the world. And this information has really brought in a new insight into the reflux phenomenon. Bovines may ruminate for self-nourishment and not for nurturing young ones. So we go back to basics. Physiology. There is intrinsic esophageal tone, which is low in the upper 1/3, medium in the middle 1/3, and high in the lower 1/3. The peristalsis in the esophagus are essentially two, the primary and the secondary. The primary peristalsis is continuous with the deglutition, and one cannot initiate another swallow or primary peristalsis until the primary wave is almost complete. The secondary peristalsis is due to local stretch, and it reinforces the primary peristalsis by carrying the leftover bolus toward the stomach. There is another type of esophageal movement which has not been well documented. Colloquially, it may be called chug-a-lug, or pouring down the esophagus. In such situations, the upper and lower esophageal sphincters are kept open, the esophagus foreshortens, the larynx moves up and down in rapid frequency, the mouth is kept open as against the usual swallowing mechanism when the mouth has got to be closed. The primary and secondary peristalsis are not seen, but there is a series of ripple waves generated in the esophagus with laryngeal movements, assisting a continuous column of fluid to move down into the stomach, but this is seen in erect posture only. There is tertiary contractions in the esophagus, which are to and fro movements when the primary and secondary peristalsis are impaired. This is non-directional, similar to the small bowel movement. Another important esophageal motility is the emptying or clearing mechanism. This is intrinsic to viscous with smooth muscle. And in certain studies, they have found that it takes 5 to 15 primary swallows to clear each one episode of a reflux. This is studied by Tuttle test, a modified Tuttle test, which is acid clearing time test. Now, just to refresh your memory about the vomiting center, the afferent fibers go to a paired vomiting center in the medulla, posteriorly located in the reticular formation. And predominantly the vagal nerves are seen to innervate this. Other cranial nerves, 1, 2, 5, 8, 9, and 11, and peripheral pain sensory nerves also take part. There is also a chemoreceptor trigger zone, which is fairly close to the vomiting center. The efferents are seen to innervate the upper and the lower esophageal sphincters, the intercostal muscles, the muscles of the stomach, the abdominal muscles. The neural afferents may convey the mucosal irritation of proximal portion of the GI tract. Even intubation may act as irritants, foreign bodies, infections, inflammations, postnasal drips in upper respiratory infection, mustard or copper sulfate on stomach form such irritants. Peritoneal inflammation and irritation are also able to produce a shower of afferents. Distension of hollow viscus is a very important factor in order to produce afferents that will trigger the vomiting or the vomiting center. The distension of the stomach, gallbladder, biliary tree, small and large bowel, appendix, ureter, and other organs. Distension of the stomach by itself can produce nausea. Pain fibers from the different parts of the body, and insult to the cranial nerves for special senses such as olfactory shock, optic shock, auditory shock, and a bad taste with trigeminal nerve involvement. Other factors are psychogenic. Anorexia nervosa is a good example. Vomiting epidemic of Jamaica is another example. Emotional stress has been documented to produce delay in esophageal emptying. There are other factors which are not transmitted through nerves but through blood. Afferents acting on the chemoreceptor trigger center, CTZ, which is located between the fourth ventricle and the vomiting center, but connects with the vomiting center. Drugs such as Ipecac, digitalis, general anesthetics, toxins like staphylococcal enterotoxins, radiation or chemotherapy, metabolic products as in diabetic ketoacidosis and uremia, hormonal factors such as in pregnancy and pancreatitis, and motion sickness from utricles through 8th nerve affect the CTC center. Just to familiarize yourself with the landmarks, the PA or phrenic ampulla is not going to be used much in our study, but distal to the phrenic ampulla is the lower esophageal sphincter or LES. V is the vestibule, which is the terminal segment of the esophagus, which is partly transhiatal and partly intra-abdominal. And if anyone tries to increase the intra-abdominal pressure and trying to produce reflux, they cannot succeed as long as the vestibule is intra-abdominal, because the fundus of the stomach will press against the vestibule, and the pressure impinged against the vestibule will make it collapse, and there cannot be a reflux. And we made a yogi to perform a similar feat to increase the intra-abdominal pressure, and we were able to demonstrate that as the pressure in the stomach increases, no material is seen to reflux into the esophagus. But there is a reflux mechanism which, through afferents reaching the vomiting center or CTZ, will go into the efferents, and the efferents will cause contraction of the longitudinal muscles of the esophagus and dislocate the esophagogastric junction into the chest, and can also produce a reflux. Now, this reflux can stimulate reflex, which as afferents can go to the vomiting center and also to the spinal centers, because this is under autonomic nervous system. So this forms a cycle. And this is an X-ray of a patient who had a surgery at the EG junction, and you can see the surgical markers. And you can see the surgical marker is about 3 centimeters above the horizontal line drawn. And in the next X-ray taken a few days later, the patient came to the hospital with some problems and worry and nervousness, and you find that this marker has traveled cephalad at least 5 more centimeters, showing that the longitudinal fibers of the esophagus has contracted and has pulled up the EG junction further cephalad. The role of hiatal lumen on reflux and vestibule. Reflux of gastric or duodenal contents into the esophagus produces a shower of afferent impulses in the esophagus, which can cause the longitudinal esophageal muscles to contract and foreshorten the esophagus. This is mainly mediated through the vagus, and this will result in cephalad displacement of the EG junction into the chest cavity, resulting in a sliding hiatus hernia. Contraction of the muscularis mucosa or the circular muscles of the esophagus do not produce any upward displacement of the EG junction, but may help in stripping the esophageal contents back into the stomach. Incidence of a reflux of gastric contents into the esophagus is high when the stomach is fully distended and when the gastric emptying is slow or prolonged due to anatomic or psychological causes. One of the subtle signs of reflux is retrograde filling of the vestibule. A greater degree of reflux may be stopped if the lower esophageal sphincter undergoes spasm. The vestibule may present like a small tent in the region of the EG junction, the apex of the tent being formed by the contracting LES. Later, in association with sliding hiatus hernia, this tent may change into a dome or a knob-like shape. The size of a hiatal lumen and its states of contraction will alter the shape of the vestibule, as well as any portion of the stomach that has been displaced cephalad into the chest cavity. Nausea can cause ileus of the small intestines and stomach and vice versa. There is acute gastric dilatation with atony. It is likely that this distension of the smooth muscle is carried through the vagal afferents to act on the vomiting center. Then the vagal efferents acting on the longitudinal esophageal muscles cause a foreshortening of the esophagus, translocating the vestibule and the GE junction into the chest cavity, so that the subsequent intra-abdominal pressure increase produced by the abdominal muscle contraction does not compress and close up the vestibule. And you can find a vestibule like a tent. The green colored portion of the distal esophagus, this is the vestibule, which normally should be partly intra-abdominal. In the X-ray, in this diagram, you find it has come up into the chest, and depending on the sphincter and the hiatal constriction, its shape may change. And we find a hernia in a patient in one study, and in another study, we may not be able to demonstrate the hernia at all. And this is because of this intermittent contraction of the longitudinal muscles of the esophagus. The anatomical factors in this region are dynamic and are not static. Here you can find a study in one patient taken during one time, but at slightly different intervals, and sometimes creating mental stress on the patient, and then talking to the patient and making him relax. And these 4 esophagogastric junctional studies were done. In 2 of them, you can diagnose a hiatus hernia quite clearly, and in the other 2, it is almost a normal appearing esophagogastric junction. This is a slide that I made about 20 years ago as the factors preventing reflux, anatomical factors. The lower esophageal sphincter, pinchcock action at the hiatus, kinking by the right crus, cardioesophageal valve, site and angle of insertion, occlusal mucosal folds in the cardia, phrenoesophageal membrane, and the compressing factors near the hiatus, sling fibers, and left gastric vessels. This still holds good. And at this stage, we will try to focus our attention on one of the structures somewhere in the middle of the EG junction, but not exactly in the esophagus or the stomach, and that is the hiatus, diaphragmatic hiatus. A gaping or patulous hiatus will permit a larger portion of the stomach to enter the chest cavity as the EG junction is displaced upward. A gaping patulous hiatus will have lax phrenoesophageal membrane and other anatomic anchoring structures such as vascular structures, whereas a tight hiatus will permit only a small portion of the stomach to be displaced into the chest cavity as the EG junction is displaced upward into the chest when the esophagus foreshortens. A tight hiatus will prevent an easy return of the herniated stomach into the abdominal cavity when the longitudinal esophageal muscles relax. A tight hiatus tends to constrict around the hiatal herniated stomach and prevent venous and lymph drainage. This will result in edema of the gastric mucosa, leading to a possibility of protein or blood loss from such edematous traumatized mucosa. This portion of the stomach, when eventually returns into the abdominal cavity, will retain the edematous situation for a period, during which time it presents as a pseudotumor of the esophagogastric junction. It may be wrongly diagnosed or very aggressively or expensively investigated with arteriograms, biopsy, or CT scans. An intussusception of the esophagus into the fundic portion of the stomach may be presumed in such cases. Let us look at Frank Netter's diagram on the hiatus and the action of the crus. I have painted or colored the distal esophagus, the vestibule, and the stomach, and the relationship and the shape of it when there is contraction and relaxation of the hiatus. The milking action at the hiatus helps in emptying the vestibule and the herniated portion of stomach. This action of hiatus can be captured on spot films, and we can evaluate whether the hiatus is large or narrow. When the hiatal lumen is narrow, the herniated portion of the stomach may tend to develop a compromised venous and lymphatic return, resulting in edema. When the herniated stomach returns to the normal position, a pseudotumor is seen, as you find And sometimes this pseudotumor is vigorously investigated with CT scanning, arteriography, and even biopsy. And here you see a large pseudotumor, which after a 15 minutes interval cleared up. Sometimes the herniated stomach may undergo torsion or volvulus in the thoracic cavity, and it may necessitate further surgical corrections to reduce it. The lower esophageal sphincter intrinsic pressure is dynamic and variable. If we consider the normal between 10 to 15 millimeters of mercury, persistently low pressure should be below 10 millimeters of mercury, and high if it is over 15 millimeters of mercury. High lower esophageal sphincter pressure may be seen as a primary cause in conditions like achalasia, or as a response to irritants following acid bathing that portion of esophagus, and there is a severe spasm of the distal esophagus. Muscle hyperplasia may be present. Vagotomy in animals but not in humans show high lower esophageal tone. High protein diet, drugs such as alpha adrenergics, beta blockers, and acetylcholine related drugs, and gastrin. Conditions that produce lower esophageal sphincter pressure may be primary and idiopathic. It may follow myomotomy, such as Heller's surgical procedures. Infiltrates, either due to collagen, such as in scleroderma, or neoplastic conditions, in certain myopathies, in toxic conditions such as diabetes, uremia, and septicemia, certain foods such as chocolate, fat, smoking, drugs which act by neurohumoral paths such as anticholinergics, beta adrenergics, glucagon, drugs that increase AMP, and nifedipine, which is a calcium blocker. There may be unconscious passive reflux related to low LES sphincter tone. When LES is brought down by neural or humoral or myogenic factors. It may also be predominant when the hiatal lumen is lax and wide. There is an augmentation effect. In such patients, when the gastric contents are brought up against a gastroesophageal junction by gravity or posture, there is reflux. Or when there is increase in the abdominal muscle contraction or gastric muscle contraction, or when there is increase in the intra-abdominal pressure due to any cause or mass effect, or tight belt or corsets in pregnancy and ascites. In certain smooth muscle disease, such as dermatomyositis and polymyositis, though the predominant pathology affects the proximal esophagus, the distal portion is eventually involved. In patients with mental retardation, you often find the passive unconscious reflux. This type of reflux is often associated with poor esophageal emptying, and the primary and the secondary peristalsis are impaired and the tone of the esophagus is lowered. Now, how to elicit non-stress reflux without raising the leg, without doing Valsalva procedures? When the patient is in prone oblique position, drinking barium through a straw, then roll the patient onto the back, first to the RAO position and then LAO. When the patient is in the RAO position, a peculiar contraction may be seen in the fundus. We will discuss this later. In the LAO position, the angle of His is opened up and the barium in the stomach is brought up against the EG junction. If the LES pressure is low, a passive reflux can occur. Immediately bring the patient upright, and if the vestibule has not still returned to intra-abdominal position, the patient may belch air in barium. If you wait till the vestibule comes to the stomach, a true reflux can then be demonstrated. Passive reflux does not have the force to influence the neighborhood even if the mouth is held open. In patients with lower esophageal sphincter pressure and passive reflux, generating multiple primary swallows seem to help esophageal emptying in the upright position. But in the horizontal position, multiple swallows can aggravate and produce more reflux. Whereas in patients with normal or high LES tone, multiple swallows can help in esophageal emptying, and erect or horizontal positions have no significant role to play. Here you find a patient with a polymyositis, and the esophagus is massively dilated. The stigmata of aspiration is seen in lung infiltrates. A lateral view shows the entire esophagus is massively dilated, permitting passive reflux, as you find in another patient. This patient has scleroderma, and you can find passive reflux, and he's developing lower esophageal stricture. Sometimes nasogastric tubes act as wicks that you find in lamps to allow the oil to come up. And they also produce enough stimulus or irritation to produce afferent impulse to stimulate reflux. Gastric outlet obstructions and delayed gastric emptying also are conducive for a reflux. We proceed now to another form of a reflux, which is unconscious active reflux, and with a reticulum phenomenon, which is seen in the gastric fundal portion. From the left to right, you see a sequence of the same patient where initially there is a constriction on the greater curvature of the stomach. It gets deeper, and as the constrictions get deeper, it isolates into a pouch, and during which time the lower esophageal sphincter is opened and there is ejection of this content of the pouch into the esophagus. Now, this is called a reticulum pouch phenomenon of the gastric fundus. So regardless of the tone and pressure of the lower esophageal sphincter, it opens as the reticulum contracts. It is not influenced by erect or supine posture. There is no involvement of skeletal muscles unless the bolus reaches the mouth. This reflux is the normal physiological challenge to promote and strengthen the esophageal emptying mechanism. And to go back to the real ruminant, the bovine cousin, we find they have got 4 sacules in the stomach: the reticulum, abomasum, and 2 rumens, ventral and dorsal rumens. And this is a sheep stomach. And you find the esophagus and the reticulum, which is almost corresponding to the human fundus, and the abomasum, which corresponds to the body of the esophagus. And I have not included the rumens in this picture. And it is from the reticulum that you get bolus ejected into the esophagus. And during which time, the graph that is taken, this was taken in a human being, and you can find the bolus getting into the esophagus at intervals. And here are the human counterparts taken in numerous studies. Here you find the constriction of the greater curvature getting deeper, and you can see the retrograde filling of the vestibule, which appears like a tent. And the reticulum has formed a full sac, which appears like an inverted top. And you can find that the vestibule and the stomach look more like a knob. And the sphincter is seen just above the vestibule. And here you find other sequences where you got reflux. And this is seen where the patient is in supine position or in the erect position. More number of cases showing the reticulum phenomenon. Here is a child who demonstrates this reticulum pouch phenomenon. You can find that the entire stomach is distended, whereas it is only the fundus of the stomach that squeezes and returns the barium back into the esophagus. You can again appreciate the reticulum pouch formation and a reflux. In some adult human beings, the reticulum phenomenon is associated with a reverse peristalsis in the esophagus, which ensures that the bolus reaches the mouth. This group of patients are called mericoles and are able to ruminate. Having dealt with unconscious reflux so far, we now come to conscious reflux. In this, skeletal and smooth muscles have an equal part to play. There are three essential types of reflux. One, conscious active reflux, which is intermittent and involuntary, and that is vomiting. There is a conscious active reflux, intermittent and voluntary, and you can call it a throwing up, like a feline or a big cat. And three, conscious active reflux, which is continuous and voluntary, and you can call it a spout out or throwing up like an elephant from its trunk. Here we have Balu, who is able to drink a large amount of water so that he dilutes the gastric acid. And then he swallows a large number of frogs and snakes. When you fold your snakes into three, it is as easy as swallowing spaghetti. The monotony of the serpentine diet is broken with frogs with all the gusto of a Frenchman. Balu then contracts his abdominal muscles like an Egyptian belly dancer to open the esophagus for the quickest snake or frog. And once it is in the mouth, Balu can bring it out slowly and with dignity. He can also expel them quickly in projectile vomitus. These are cleaned and returned for a future performance. Now, these trained yogis can demonstrate reflux. And we gave barium to snakes and frogs, and a catheter and a syringe ensured full cooperation from the snakes. Some of the snakes have learned to regurgitate barium, having participated in the act so often. And here is a snake with barium in its belly going down a bolus esophagus and into the stomach. They are alive and well and quite active. Balu demonstrates how he can bring them up. Balu now demonstrates intermittent reflux, which resembles vomiting. There is spasmodic contraction of the pylorus and the prepylorus. The vestibule is already in the chest. And here is Apparao, another yogi, demonstrating again intermittent contractions. They bring in the gastric contents into the esophagus in the first stage, and in the second stage, they throw it out. During this spasmodic contraction of the pylorus and the prepylorus, the vestibule is dislocated into the thorax due to longitudinal esophageal muscle contraction. The diaphragms contract and come down, the abdominal muscles contract, the intercostals contract. And we took the pressure in the esophagus and in the stomach. And this is a normal pressure. And this is a diagram of how the contraction in the pylorus causes the gastric contents to go into the esophagus. And this is the pressure tracing and showing the stomach emptying its content into the esophagus, the esophageal pressure going up. And as the esophagus empties, the pressure dropping down. And this is repeated. This intermittent contraction is often associated with a vomiting. During the time of reflux, there is a bradycardia, and even when the reflux material is in the lower esophagus, a cough reflex is stimulated. And so you may often find cough and vomiting going hand in hand. These are all different people who are able to demonstrate this. Now, it is very important to realize that the gastric contents that are thrown into the esophagus create a tremendous intraluminal pressure within the esophagus. The esophagus is contracting upward and it is being stretched. The hiatus is acting like a fulcrum. The diaphragm is contracting down. The abdominal muscles are contracting, and the stress or a shear is created in the portion that is adjacent to the hiatus, that is the fundal portion of the stomach or the distal portion of the esophagus. And they can undergo trauma that can be a rupture either of the mucosa or the muscle. The next patient is one of the yogis who demonstrated what happens within the esophagus when the gastric content that is thrown into the esophagus is not allowed to come out, but he is keeping it inside. This is similar to choking back a vomitus. And here is a gastric content which has gone into the esophagus, and then the esophageal pressure goes up. It went up beyond 500 millimeters of mercury, and I could not even document the full amount. And the pressure was going up and down, and then I asked him to throw it out, and then the pressure dropped. Here is another friend demonstrating that though it is a very colorful phenomenon in the proper setting, choking back a vomitus or an intermittent reflux may be a dangerous situation. Now, Day is going to show how a continuous reflux is performed. This is different from the intermittent reflux he showed a little while ago. He drank clear, cool water from the jug and filled the jug right back with clear, cool water. During this continuous reflux, there is no contraction in the pyloric region as you saw in the intermittent type, but the contraction is more on the fundal portion of the stomach. If the hiatus is lax and wide, a considerable portion of the stomach can be herniated into the thorax. The upper and the lower esophageal sphincters are opened wide, and the fundus squeezes and injects its contents into the esophagus, which goes straight through the esophagus, through the mouth, outside. And during this time, the pressure studies have been taken, and they show how the intragastric pressure goes up and empties the bolus into the esophagus. The esophageal pressure sort of comes down slowly because the stomach is still partly in the interthoracic region. And if the hiatus is not so lax, only a small portion of the stomach may herniate into the thorax in order to facilitate a reflux. But the upper and the lower esophageal sphincters are held wide open. And again, the fundal contraction causes its contents to be injected into the esophagus and out through the esophagus outside. And here is the pressure tracing taken during such phenomenon. And you can see the intragastric pressure had gone up, but the esophageal pressure does not go up at all. The esophageal pressure stays flat because both the upper and the lower sphincters are held wide open. Here we see the cine radiography of continuous reflux. And you can see the pyloric portion does not contract, but it is the fundus that predominantly contracts. A small sliding hiatus hernia is inevitable. Depending on the hiatus lumen, a large hiatus hernia may be produced and reduced at will. This is not necessarily a thing that yogis can do. This can happen in all of us or any of us. Any of us can learn to produce and reduce a sizable hiatus hernia. Any of us can also produce intermittent or continuous reflux at will if we choose to do so. The power lies dormant within us.